Now the nervous system manifestation include the mononeuritis multiplex, mononeuritis multiplex. It can cause the peripheral neuropathy, in gloves and stocking distribution. It can cause the compression neuropathy like the carpal tunnel syndrome, carpal tunnel, and the tarsal tunnel. And compressive neuropathy in the cervical cord like the atlantoaxial subluxation will compress the spinal cord and it lead to quadriplegia. Atlantoaxial subluxation can lead to compression of this cervical spine and will lead to quadriplegia. So these are the nervous system manifestation of rheumatoid arthritis. Now the rheumatoid arthritis diagnostic criteria. This one is the old criteria and this one is the new criteria. The old criteria include the morning stiffness for more than 1 hour for at least 6 weeks, and arthritis of at least 3 joints simultaneously, that is MCP, PIP and rest joint, for at least 6 weeks. At least 1 hand joint arthritis for 6 weeks. Symmetrical arthritis and rheumatoid factor are anti-CCP positive. Rheumatoid nodule and erosion on X-ray. So if there are 4 out of these 7 components, it makes the diagnosis of rheumatoid arthritis. This was the old criteria. The old criteria is complex, it is more clinical, but it may miss the diagnosis in some cases. And as we know that rheumatoid arthritis is an erosive and deforming arthritis. To prevent erosion and deformity and to easily diagnose the patient, in 2010 the American College of Rheumatology established a new criteria, that is the 2010 ACR criteria, American College of Rheumatology. This criteria include the 4 components: joint involvement, serology, acute phase reactant and duration. And to easily remember these 4 components, the mnemonic J SAID is used. Now in the joint involvement, if there is 1 large joint involvement, it has 0 score. If 2 to 10 large joints are involved, it has got 1 point. If 1 to 3 small joints are involved, it has got 2 points. And if 4 to 10 small joints are involved, it has got 3 points. And if there is 10 large joint involvement with having at least 1 small joint involvement, this has 5 components. So the more the small joint involved, the more is the number. The second component is the serology. Serology means the rheumatoid factor and anti-CCP. If these are negative, it has got 0 point. If these are present but present in low titer, low quantity, it has got 2 point. And if these are present in high titer, it has got 3 point. Acute phase reactant, that is CRP and ESR. If this is normal, it has got 0 point. And if this is raised, it has got the 1 point. And the last component is the duration. If the duration is less than 6 weeks, it has got 0 point. And if the duration is more than 6 weeks, it has got 1 point. So if there are 6 Out of 10, it make the diagnosis of rheumatoid arthritis. Now the investigation which is done for the rheumatoid arthritis include the complete blood count, and as we know that rheumatoid arthritis is a chronic inflammatory condition, and any chronic inflammatory condition will lead to anemia of chronic disease. So there will be anemia of chronic disease. The inflammatory marker, that is ESR and CRP, will be raised. Rheumatoid factor, which is actually IgM against the Fc portion of IgG. This is a test which is done for the rheumatoid arthritis, but this test is neither sensitive nor a specific test for the rheumatoid arthritis, because it is positive in many other conditions. And to easily remember the condition in which the rheumatoid factor will be negative are the She pill in love with general system. That is, She is for the Sjogren syndrome, pill is for the Pilty syndrome, IN is the for the infective endocarditis, love is here for the lupus, means systemic lupus erythematosus. General means general population. It is positive in 5% of the general population. And S here is for the scleroderma. This is neither a sensitive nor a specific test. A specific antibody anti-CCP is done for the rheumatoid arthritis. This is more specific than the rheumatoid factor. It is positive, it is specific in 95, it is 95% specific for the rheumatoid arthritis. We can also do the giant fluid analysis to exclude the infection. Now X-ray of the giant can also be done. There it will show the early changes and the late changes. The early changes include the soft tissue swelling, loss of joint space, juxta-articular osteopenia, and the late changes include the erosion and subluxation. So these are the investigation which is done for the rheumatoid arthritis. There are three syndromes in the rheumatoid arthritis, and the examiner commonly asks question about these syndromes. One is the Pilty syndrome, the other is the Kaplan syndrome, and the third one is the carpal tunnel syndrome. So what is the Pilty syndrome? Pilty syndrome is the rheumatoid arthritis, neutropenia, plus splenomegaly. Due to neutropenia, these patients usually present with the infection like pneumonia or UTI. The second syndrome is the Kaplan syndrome, rheumatoid nodule in the lung plus the pneumoconiosis. This is called the Kaplan syndrome. And the third one is the carpal tunnel syndrome, which is the compression of median nerve. Compression of the median nerve. So these are the three syndromes which are commonly asked in the exam. Now the poor prognostic factor in rheumatoid arthritis include the insidious onset. This has poor prognosis because sudden onset is not a poor prognosis in rheumatoid arthritis. Late age presentation is also a poor prognosis, and positive rheumatoid factor is a poor prognostic factor. Anti-CCP positive is a poor prognostic factor. HLA-DR4 is positive is having a poor prognostic indication. And early erosion on X-ray is also one of the indication for the poor prognosis. So similarly, female sex and rheumatoid nodule, if present, this also indicate the poor prognosis in rheumatoid arthritis. Now the treatment of rheumatoid arthritis include the DMARD. There are two types of DMARDs. One is synthetic DMARD and the other is biological DMARD. But when we diagnose the patient with rheumatoid arthritis, we start the bridging therapy. Bridging therapy include the methotrexate plus steroid. Methotrexate takes time to start its action in 2 to 6 weeks, and steroid will start work suddenly. So we start the methotrexate along with the steroid. Uh, in 2 weeks we taper the steroid and we continue the methotrexate. This is called the bridging therapy. On synthetic demand and biological demand, we have uploaded video. So also watch this video. Thanks.